the ease. Okay, this is what the ease expander looks like. This is the KLS Martin expander.
Mm-hmm.
My understanding is that it requires cutting into the gums in order to install it. But critically, the way this expander works is that it's placed posteriorly, which is to say further back than um, a custom MARPE, which would be represented here on the right, which is more anteriorly placed in the denser part of the maxillary bone, which is toward the front. Because as we get to the back, toward the PNS, the posterior nasal spine, the bone gets thinner. Um, and that is borne out in this image, which is a graph that represents bone density in the maxilla based on location. In the front, well, on the midline, we have dense bone from the front to the back. But as we deviate off of the midline, the bone density is more in the front. This yellow represents 4 to 6 millimeter bone density. And as we go farther back, it gets 2 to 4 in these sort of salmon colored blocks. And then the red blocks are very thin bone, which would be, posterior placement. Here we have the molars, and the bone is very thin as we flank to the side of the mid palatal suture line. And so, the MSE was famously placed more posteriorly, but there were lots of failures because the MSE TADs would drag through the thin bone, and perhaps for other reasons. But the ease expander is posteriorly placed into the alveolar bone, which is to say the force vector of the TADs, or the placement of the TADs, is parallel to the direction of the expansion as opposed to perpendicular to it with typical MSE TADs. And so it's pushing into the alveolar bone posteriorly, and along with Casey Lee's sort of mysterious surgical assist, which we don't really have details on. He doesn't disclose that information for whatever personal reasons, maybe to protect his procedure from other people doing it. I'm not sure. But with his surgical assist, which is through the nose, it's endoscope assisted, hence ease, endoscope assisted surgical expansion. This expander is able to, purportedly achieve a parallel posterior expansion, a parallel front to back, as compared to the custom MARPE or MARPEs in general, which achieve this sort of more conical expansion, or at least so the naysayers purport. Okay,
Mm-hmm.
but I want to give you a chance to make the case. And here's my MSE, by the way. So this is not ease. This is Juan Moon MSE. My MSE was obviously, the expander has been through 86 turns at this point, 84 turns. It's completely mangled. There's possibly flaring of some teeth, but you can see that the appliance was posteriorly placed at my first molar, right?
Mm-hmm.
So whereas the custom MARPEs are more anteriorly placed up here toward the ANS area, where the bone is much thicker. So I want to give you a chance, doctor, to respond. And here's another image, ease after 10 days, where you can see this is just 10 days post-op. You see a parallel split front to back, where you have a gap forming at uh, the PNS, the posterior nasal spine, the back, which is sort of the supposedly the gold standard of where you want the expansion in order to have airway benefit.
Mm-hmm.
Um, all right, I will let you respond, doctor. Here's one more image with ease. See, you get this robust posterior expansion, or at least in this case, with this KLS Martin expander, which is placed at the first molar, as opposed to anteriorly toward the front of the maxilla.
Mm-hmm.
All right, that's my steelman argument in behalf of ease and against custom MARPE, represented on the right in this photo.
Mm-hmm. So, can you go back to the clinical pictures of the KLS Martin expander?
This image,
The clinical, the intraoral photos.
yes.
Yes, thank you. So when you look at the placement of the device in this image is not placed posterior and is not placed anterior. It's placed exactly in the center of the maxilla from the front to the back. Um, The reason why in some of the case, can you go back to the 10-day after ease image that you showed recently?
This one?
Yes. So when you look at this 10-day post-op, and you're saying that the opening of the mid-palatal suture is parallel from the front to the back. My understanding is that the ease activation is very minimal, very slow. Otherwise, the expander would fail and cause impingement on the gingiva. So I think what you are seeing on this image at day 10 is the activation that the surgeon got during the surgery, not much at home. The patient may have just started to turn. So you are really seeing the surgical cut. So this is a surgical cut. This is not the expansion that we see on those CBCTs. And although the cut looks nice from the front to the back, that's great. And I understand that this cut is done with the endoscopic approach, which we also are trying to achieve with the two-pan approach at the University of Pennsylvania Sleep Surgery Department. So I like the cut, but I would like to see this patient after the expansion, after all the turns are completed, because I have seen enough patients after ease where this widening that you see in the paper that you just shared, where you have a beautiful wide opening of the mid-palatal suture from the front to the back. You just don't see consistently on all the patients. Like this is great, and I like the idea. This is more posterior placement of the screw on this image for sure, and I like the control where if you need more posterior expansion, you place the screw more posterior. And you get less diastema, less opening in the front. That's awesome for some of the cases, but some of the cases really require more anterior expansion, unlike this case. But it's not a consistent outcome. And we can't really claim that this is the only procedure that will achieve that posterior expansion.